Welcome to Talking Meds on the PrescQIPP podcast, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill. Hello and welcome to this episode of Talking Meds. I'm joined today by Dr. Lucy Pollock for the second in our series of podcasts called Sensible Prescribing in Older People with Jonathan and Lucy. Hi Lucy, do you want to introduce yourself again to our listeners?
Hi, my name's Lucy Pollock. I'm a geriatrician in Somerset in the southwest of England.
So this series is all about sensible prescribing in older people. We're particularly concerned about prescribing in older people because older people tend to have more conditions, therefore more medicines prescribed for them, and that can come with some problems. This series is all about Lucy sharing her wisdom that she's acquired through a long and extremely fruitful career looking after people who are in the older stages of their lives. So this example, Lucy, this is about a lady who you came across a few years ago, isn't it? Do you want to just share with the listeners what we're on about today?
Yeah, so this is a common problem, and it's one that I wanted to talk about because this is about the balance of benefit and harm in frail older people. And it's also about how we talk about medication and what expectations we're giving to families and to patients themselves when we prescribe. And we know since the dawn of time, for at least 2,000 years, that doctors have habitually overestimated the effectiveness of medication and have underestimated the side effects of medication, and we tend to be very good at passing exactly the wrong information also on to our patients and their families. So we build expectations about medication, and we also give people a burden of concern about whether somebody should or should not be taking medicine. So I met Brenda some years ago, and she's a lovely 88-year-old retired teacher who lives with her family, a very lovely daughter and a very patient son-in-law. And she's a very sweet lady. She has significant dementia, and over recent years has really begun losing a great deal of language as well, and she's become increasingly frail. And among her many medications, she's taking all sorts of medicines, some for her diabetes, and some she's still on a statin. We'll come to that in another episode. And she had an MI a few years ago, and she's been on a low dose of aspirin ever since then. But more recently, she's had some falls, she's become increasingly frail, and her GP has very sensibly done some sensible blood tests, which include a full blood count, which shows that her haemoglobin is slowly dropping. And we look at her MCV, and that's dropping too. He adds in a ferritin, and it's only 6. So, dear lady, she has undoubtedly got an iron deficiency anemia. Now, she has no red flags for malignancy, and also she and her family are very clear that she wouldn't want any investigation. The idea of having an OGD and a colonoscopy is really beyond things for Brenda. That is not what she's interested in having. But actually, she's probably not got cancer. What's much more likely to be the problem is that the aspirin is slowly and inexorably giving her some GI bleeding. Aspirin causes GI bleeding throughout the whole gut, not just in the stomach. It goes right down to the small intestine and even into the colon, and can cause microscopic bleeding all the way. So the question then is, do we just stop the aspirin? And her family say, well, she had a heart attack. She was told when she had a heart attack that she must take the aspirin every day to stop her having another heart attack. And Jonathan, I think you're familiar with that message that people get. This is to stop you having a heart attack.
That's right, yes. It's about reducing the risk of having a heart attack in the future, not eliminating the risk, because there's a risk in everything we do.
Absolutely.
Lying in bed is a risk, isn't it, Lucy?
Yes. So what I try and teach my doctors in training that I'm working with is, please don't say, oh, this is to stop a heart attack or to prevent you from having a stroke. It won't stop or prevent anything. It will marginally reduce the risk. The difficulty, if we use such binary language, we're giving the impression that if you continue to take the aspirin, you won't have a heart attack. If you stop it, you'll have a heart attack tomorrow. And that puts a huge burden onto our patient and onto their families, especially for somebody who might be struggling to persuade somebody with dementia to take their tablets each morning. And I have families who literally spend half an hour first thing in the morning trying to persuade somebody to take their medication, cajoling them and trying to get those tablets down them, because they think they're doing the right thing. And if they don't do this, that person's going to drop dead. And that's a very bad message to give to people. It comes with a whole load of guilt and worry that frankly you don't need when you're already looking after somebody with dementia. So the question is, how do we reassure somebody that actually it's reasonable to stop the aspirin? One of the recent developments is a much better evidence base that helps us explain this kind of decision to families. And one of the ones I absolutely love, we'll come back to some others another time, but the one that I really am keen on at present was developed by Julian Treadwell, an academic GP now working in Oxford, and it's called GP Evidence. And if you can right now or after this podcast, just Google GP Evidence and you will find it very quickly. It comes up top. And you will see a drop-down list once you've agreed to join the website. You don't have to sign in, you can see it immediately. And you will see various conditions and you can click on coronary heart disease. And very quickly, you can see the various interventions that you might suggest, like smoking cessation and a Mediterranean diet. And further down, there's something about antiplatelet therapy. And what this website does is gives you some beautiful Kate's plots. Those are the ones with the smiley faces, green smiley faces if nothing bad happens, red faces if something bad happens, and a yellow face for something bad having been averted. And you will see placebo versus aspirin, and it will give you what the benefits are. And it lays it out beautifully, because what it does is it illustrates that although there is a relative risk reduction that's quite significant with aspirin, it does reduce your risk of having another MI or a vascular death. The actual risk reduction is very small. It's 0.6%. And that translates for vascular mortality into a number needed to treat. This is how many people have to take that medicine for 1 or 2 years to prevent one of them from having a heart attack or a stroke and dying of it. The answer, that number needed to treat here, is 166. So 165 patients are taking that aspirin every day with no benefit. We can change the figures a little bit, and we can change it to just non-fatal MI. We'd much rather she doesn't have another heart attack putting her in hospital. But even then, the number needed to treat is 111. And what's lovely about this website is for some families, it just creates this wonderful moment of clarity. And I've had a family, Brenda's was the first, looking over my shoulder at the computer, pointing to the one smiley face out of 100 and saying, well, it's not worth it, is it? For our mum, it is not worth her continuing to take the aspirin. Really importantly, it's not about that Brenda isn't worth it. Brenda's worth everything. It is that the tablet is not worth her taking. It's the tablet that's not worth it. It's not doing her enough good to offset the fact that it's now giving her an iron deficiency anemia that's going to cause her problems.
It's interesting, Lucy, isn't it? So, yeah. Because this is about values and preferences as well, isn't it? So for some people, if you say to them, if there were, Brenda, if there were 100 people like you, and all of you took aspirin, then one Brenda in the future will be prevented from having a non-fatal MI at some point in the future. We don't know whether you're going to be one of the persons who wouldn't have had this bad thing happen to you in the first place. We don't know if you're going to be this one person who's still going to have the bad thing happen to you, or we don't know if you're going to be the person who's been prevented by having the bad thing happen to you. Some people, though, Lucy, might say, oh, 1 in 100, that feels quite high. I want to take the aspirin. Whereas others, like me and you, I think, would say 1 in 100 isn't worth it for me.
Yeah,
it's just not.
You're absolutely right.
And I think the other thing that changes here when you look at because you always have to look at the harms as well as the risks. the harms have already started happening to Brenda, haven't they?
Yeah.
This isn't a theoretical thing that might happen. She's got signs and symptoms of an active GI bleed now. So it's not a 1 in 200 chance of her getting a GI bleed. It's a 1 in 1 chance because it's actually happened to her.
Yeah, you're absolutely right to point that out. And you're so right about people's perception of risk. And again, this is why I'm trying to get people to move away from blanket saying, oh, you're at high risk. You're at high risk of stroke or high risk of heart attack. What does that actually mean? Because for some people, a 1 in 25 risk feels not too risky. For others, 1 in 25 is a terrifying risk. So it is very much down to the individual and often the condition as well. So I may have a patient who's much more worried about having a stroke than having a bleed, for example. Understandably, because her mother died after a horrible stroke and lived with significant disability, and she will do anything to avoid having a stroke. So it is all about listening to your individual, giving them the information they need to make a decision. Now, we know that lots of other people will say, actually, I don't know. What are you talking about, doctor? You decide. And that's fine. You know, that's what my training enables me to do. But for a lot of people, given the right information and given a bit of time and support, they really do see that they would like to make their own decision about this. And it does that thing of taking the burden off the family.
Yeah.
If she goes on to have a heart attack, that heart attack may well have happened anyway. Do not feel guilty about this decision. We can make very good decisions that don't necessarily turn out well, and that's fine. Do not let anybody walk out of your consulting room feeling guilty about a decision.
Absolutely. I hear this all the time. People say, you know, what would you do, Jonathan, in my situation? And I say, well, I'm not you. You know, I make different decisions to you every day. We wear different clothes. We have different cars.
Mm-hmm.
We have, and we also make different serious decisions every day because we have different values and preferences. So what I can do to you is explain the risks and benefits, and for you to decide what's important to you, what really matters to you, or indeed what your family think. Because again, sometimes if somebody hasn't got the capacity to make that decision, then it is on the family sometimes to make that decision on their behalf, and I think that's fine. But no, I always say, well, what would you do? Well, I'm not you, and why would you ask me? Because you know we have different values and preferences.
We'll come to the right decision together. And in the end, if you really want me to make the right decision, you know, or to try and make the decision for you, that's fine. But let's have that conversation and feel confident when you leave the room that you know that this has been a good decision, whatever the outcome is. That it's very rewarding doing this job.
Indeed. And something else you said earlier as well. Sometimes people make a decision for the now, but you're allowed to change your mind, whether in a week's time or a day's time or a month's time. And something like taking aspirin, you don't lose all the benefit just by stopping taking it. If you start taking it again, you will then potentially, it gives you that protection again. You are allowed to change your mind here.
But and we'll talk about drug holidays in another episode, because that's a great way to help people work out what the right medication is for them.
Lucy, thanks so much. That's been so helpful. A really practical insight into what can be a tricky issue to help people with. I hope you found this useful, guys. Please do let us have your feedback via our social media channels or suggestions for topics or future guests for the pod. Really open to ideas for this, and hoping you're enjoying it. Lucy and I will be back in 4 weeks' time for another episode of Sensible Prescribing in Older People with Jonathan and Lucy. For the next episode of Talking Meds, I'm delighted to be joined by Claire Howard, and we're going to be talking about the Repeat Prescribing Toolkit, which has just come out as a joint publication from the Royal College of General Practitioners and the Royal Pharmaceutical Society. Claire was the person who led that project, which I helped with as well. So we're going to talk about that, and something that we think you guys should be really excited about as well, because it's a really useful toolkit. So we'll see you then in 2 weeks' time. Cheers, guys. Bye.